Thank you, first of all, for the nice introduction and for the invitation to be able to speak here. The last speaker already mentioned quite a lot about pulse radio frequency, so there will be some overlap, but that's good for the memory. Okay. So I will tell my topic of today is the Sacral pulse wave. That's a technique I invented by chance in 2009. I did already more than 2,000 cases. I think it's a valuable additional technique for every intervention with pain. It has changed my practice algorithm. So every chronic patient, pain patient at intake is checked if there is tenderness over the spinous processes in bone position. I will tell you about the indication, the technique, the new developments in pulse radio frequency. We heard already quite a lot from Dr. George. The results of the technique and the possible working mechanism and basic science. So the indication is central sensitization, and I hypothesized about it that you could diagnose it very simple by checking the tenderness of the spinous processes. And I do it like this. I mark on the skin where it is painful. For during the treatment, you will see that the pain will go away. That's the stunning effect. And if you press again then during the treatment, the patient says, did you press that hard at the beginning? And then they are convinced that it helps already. So here's the technique. The technique is in prone position. You look at your velocity in the lateral position, identifying the sacral hiatus. Then you do some local anesthesia, and we developed a special electrode, the topic say 1515 without temperature measurement, into the sacral canal, and not further than S3, because the dual sac ends at S2. But they have two cases where the dual sac ended at S4, so you could be aware that sometimes you could see leak. We put the ground plate on the high thoracic spine, and we do electrical stimulation to see the thresholds where the patient can feel something. And depending on that, we decide which voltage we should use. Nowadays, I use pulse radio frequency slides attack 0%. I will tell you about that more. There's P or 5.5, never 220 again. 220 is not needed and could give complications. And we use that current for about 10 to 20 minutes, depending on how much of the pain is going away. So you see a development of analgesia from distal to proximal, the so-called stunning effect. And you can see the results right away, so that's the acute effect, but the definitive effect you can only judge mostly after 2 to 3 weeks. And it can last for 2 to 12 months, and you can repeat it without complications. So how did I get the idea? If you look at the literature about cold epidural injections, this is the systematic review. It's frequently used in lumbosacral pain. Local anesthetics, even without corticosteroids, could have a remarkable long-term effect. And it seems to be a special spot. So then I thought, could sacral PRF be a special treatment? Here you see the anatomy again. You see again how close we are to the DRGs. Where's the marker? There's the marker. Right. Here, you put the needle here, so you are very close to the DRGs. We heard already from the last speaker that what is pulse radio frequency? Pulse radio frequency has a frequency of about 420,000 hertz. And if you put an electrode into the tissue with a ground plate with an active tip, there are two things happening at the tip. Not only ablation, but also electric fields, even with a heat, with a continuous pulse radio, radio frequency. So if you compare the strength of the electric fields between pulse radio frequency and radio frequency, you see at the above marker awareness. So you see at the upper level, that's the electric field of the heat radio frequency at the shaft and the tip of the needle. And the under part, that's the pulse radio frequency. And you see there's a factor 4 difference. So there's a stronger electric field in pulse radio frequency. Rampersad was working in Rohof University, and there has been a publication of Meadows-Luiten and Alexander Teixeira about intravenous pulse radio frequency. They wrote an article about it, and they applied intravenous in the axillary vein pulse radio frequency with remarkable results. Not everyone, but some with remarkable results. And then they could attract the attention of the oncology department, and they did investigations how strong is the electric field when they apply that pulse radio frequency. And that's about 1 to 200 volts per meter. So if you look at what happens at the tip of a needle, of the shaft, where is it 200 volts per meter? 200 volts per meter is about 6, here, this line, is about until 5 centimeters around the tip of the needle. There's the strength of the electric field is 200 volts per meter. And why is that important? Because cells communicate with an electric field of 200 volts per meter. So these are important figures to consider. So new developments, we went from RF, continuous pulse. The parameters have changed. Why? Because there were heat spikes. That was the work of Kosman and Kosman. They did investigations. And when you see on your generator the temperature measurement, you see that's about 42 centigrades. But when you measure it more accurately, they did that, and then they saw these heat spikes. So that is not what we want to do. We want to have no heat. So the parameters have changed. Since 2009, we use now 5.5. And when you have 220, then we call that duty cycle 40. And you use 5 frequency and 5 milliseconds, the duty cycle is 25. And since 2015, we went over to Sluiter-Teixeira-Poisson. That's an irregular burst type of radio frequency with a duty cycle of about 15. Or you can also use 3.5, that's enough. This is the Alexander, the STP pulse rate. So we went over from invasive also to transcutaneous pulse rate, and I invented the Sacral pulse rate for treating central sensitization, and it works also in many fibromyalgia patients. Here you see what you can see on the X-ray. The simple techniques is the caudal epidural, in fact, caudal needle, and the working mechanisms. Well, we talked already about it before. We think first we saw that it was only neurocentric, that it worked on neuromodulation. Now we know that it works also immune-inducing, and it works on the reduction of oxidative cell stress. So the role of the immune system and in oxidative stress for pain and other diseases. Also, other diseases could react on pulse radio frequency because it can diminish oxidative cell stress. So the first publication was this article. We then called it caudal pulse rate. Now we call it sacral pulse rate in 3 post-operative neuralgia patients. And you can read the article. There's also the technique described. So I want to emphasize, as a pain specialist, you should be taught about physical examination. Physical examination is utmost important. And you can have much information for the correlation between indication and which technique you should use. So, and in books sometimes it's said that it is called unreliable, but that's bullshit. It is wrong. Many things we can diagnose is better with physical examination than with an MRI scan. But you have to be being taught about it. So tenderness over the spinous process is a very important test, I think, in every chronic patient. The last 3 years, a few psychotherapists sent me some chronic stress patients, also burnout patients. And even then, this technique is helpful. And also post-COVID patients were sent to me, and they had some remarkable results. So Sacral PRF could be supportive in the total treatment program. So until now, there's no good investigation to show whether there's central sensitization. And central sensitization, to my opinion, is an inflammation. This is the technique I showed you. There is no definitive method to diagnose it. You could use the clinical symptoms, functional MRI, or quantitative sensory testing, but it's all pretty complicated. This is a very simple, useful technique in daily practice. Something about, yeah, we heard already very much about nociception and pain. So nociception, only nociception causes no pain, but the brain is always involved, and then it becomes pain. So there's a continuous interaction between ascending and descending information, with facilitation and inhibition. Always the emotional brain is involved, it's giving recognition and significance. Always psychological, cultural and social factors are involved. Holistic treatment, and chronic nociception can induce neuropathic pain because of the plasticity, and what is developing is then a chronic pain memory and pain matrix, pain signature. This is the descending inhibitory system. As you see on the right side, here you see the nociceptor, spinal cord, but there's a descending inhibitory system, and PRF also works on that system. There's an article about it. I'll show you. So what is the definition? The new definition of the YOSP is an unpleasant sensory and emotional experience associated with or resembling that with actual or potential tissue damage. Chronic nociceptive pain, inflammatory pain, may become neuropathic because of plasticity. And neuropathic pain cannot be blocked with ablative method, that's contraindicated. Chronic pain is not a symptom, but becomes a disease. And always three systems are involved: the neurological system, the immune system, and the endocrine system. All are involved in chronic pain. After treatment of nociceptive foci, neuropathic pain can remain because of the central sensitization. Are there other possibilities? As many speakers already said, we have to have a holistic approach, and the biological, the social, and the psychological factors should be considered. Don't treat a joint, we treat always a patient. And in many diagnoses, central sensitization can occur. In all these daily practice diagnoses, central sensitization can be involved. And here you see a picture of the pain matrix with the sensory discriminative aspects, the affective aspects with the centers in the brain, and the associative factors. And I made also for my patients and for my hypothesis, I made this picture. And if you have chronic pain, chronic spinal pain, always consider psychosocial factors. And you could have pain from the medial branch, then you block it. Some people will be better, but many people will not be sufficiently treated. So many, here you see the technique. You could have pain of the segmental nerves, the dorsal ganglion, and I treated in the last 25 years many patients with DRGs. It's one of the most effective treatments in pulse radio frequency. But I advise you to do 2 levels, not 1 level. Most people need 2 levels because every part of your body is multi-segmentally innervated. Find the central the tenderness of the spinal process. And one of the options to treat that is treat the sacral PRF. And of course, we can have the placebo effect. So here is another example. What I want to emphasize is that you have always to consider what is the reason that this patient has a central sensitization. This man had a chronic radiculopathy, S1, and when I treated only the S1, it had no effect. But when I treated both, so the trigger, the DRG, S1, together with centralization, then only it worked. So consider what's the focus, what's central sensitization, and in many cases you can combine the treatment in the same session. It's relatively simple. So, we heard already from the last speaker, PRF of the dorsal ganglion, peripheral nerves. I have the second generator from Minnesota in 1997, and I started doing the peripheral nerves, the suprascapular nerves, and many effective peripheral nerves can be treated. Intra-articular disc, there are many RCTs with good results. You see the technique which I improved is the lateral view, the lateral technique for the AA joint, a very effective technique. But don't inject anything in the AA joint, just do PRF. If you inject something, there can be complications, and especially no particular steroids in that region. When is radiofrequency heat pattern and pulse? Intrageminal neuralgia, the medial branch in the lumbar region, sympathetic ganglia. There is no publication that PRF with RF could work better than the genicular nerves, but in my hands, PRF is also effective. So, if we look at conditions connected with inflammation in the pain syndromes, neuropathic pain can be caused by peripheral nerve trauma, spinal cord injury, inflammatory conditions in the spinal region, in the peripheral region, in the post-traumatic region, and in CRPS. And if we look at sterile inflammation, what is happening? The inflammatory status of the whole body is continuously monitored. The efferent system means that there's visceral inflow from the vagal nerve, and the musculoskeletal is being focused by the DRG efferents that exclusively innervate lymph nodes, and emotional stress. Emotional stress comes from the prefrontal cortex. And here you see what happens. So the inflammation is going to the vagal nerve, the efferent vagal nerve, and the mental stress comes from the prefrontal cortex, and it comes all together in the tractus nucleus solitarius, the 11th cranial nerve, and then it goes to the brain. And then there's a reaction in the brain, and it gives downregulation of the immune cell activity by the sympathetic stimulation of the locus ceruleus. So another thing, what it could be the explanation how the sacral pulse breath works, is because of this publication of the inflammatory reflex, the cholinergic anti-inflammatory reaction, published by Kevin Tracy. What you see, if you see what happens, if you have an infection, an injury on the ischemia, an inflamed zone, then you get the efferent vagal nerve is being sensitized by the cytokines, and you get the sensory vagal nerve. Then the motor vagus nerve excretes acetylcholine. Acetylcholine is an inhibitor of the inflammatory reflex. The other reflex is as I told you just before, is the sympathetic. The sympathetic causes adrenaline and noradrenaline, also diminishing the inflammation. And the other thing what happens is the endocrine system is also the hypophysis, pituitary and renal axis. So the cholinergic anti-inflammatory pathway, as we described by Kevin Tracy, you see that the efferent vagus produces acetylcholine, inhibiting the inflammatory responses, and it works on the alpha-7 subunit of the macrophages. And there are several therapeutical applications. You could also use direct external vagus by stimulation here, or that is used by epilepsy, rheumatic disease, and other diseases. of the gamma choric cluster headache. You could use it pharmacologically by on the CNF, the vagal nuclei, stimulating it intracellularly, and small molecules acting on the alpha receptor unit. And my suggestion is, my hypothesis is, that sacral Dusit could work on this mechanism. So in the last decades, we've gone more and more over to electric receptacles instead of pharmacoreceptacles. You see again a picture of that. You see the cholinergic anti-inflammatory pathway, and this is the sacral Dusit. And the pathway here, this is the conditioning. The static inhibitory system is being stimulated by these methods: meditation, neurofeedback conditioning, acupuncture. You have psychoactive inflammatory agents. You have direct vagus stimulators here applied to the neck here and to the abdomen. And you could also use local cholinergic agents like nicotine patches or other agents. And perhaps pulse radiofrequency is working, or sacral Dusit is working on the same mechanism. So I told you already about the technique. So markable tenderness of the spine's processes. I think it's central sensitization. We use an SCK or a topic, not a new topics AC1550 with an active tip and the ground plate on the hypertonic spine. And we do 10 minutes, principally PRF STP. Sometimes after 10 minutes, the lower part of the body is pain-free, but the upper part not yet. And then we go over to expanding the time to about 20 minutes. This is the article, so the remarkable stunning I told you. And this is a slide of Nodule, the Nodule clinic where Menno Sluiter many years worked. And one of his disciples, Uli Kalmbach, he made this presentation, and he had, in the Nodule clinic, is a clinic with paraplegic patients. You see here that's 7 very difficult patients. The 5 of 7 reacted well on the treatment. Here emphasized, this is this had no effect. Here you see spina bifida occulta, spinal adhesions, neuropathic pain, incomplete paraplegia, even reacted mixed sacral pain, coxally incomplete tetraplegia, and perigenital pain, pudendal neuropathy. And this is a very simple technique without complications. And we give every patient, we give this form. They have to fill out every day the pain score, and then you see what happens in this patient. That in the beginning he had still pain. He had a stunning of about 1 day, but afterwards it lasted 2 to 3 weeks before the pain was diminished. And this is the second month, and you see that it still has a good effect. Another case, she had a stunning effect, and it lasted right away for 2 months. These are the results of the 109 cases I investigated. You see here the diagnosis, the number of treatments, more than 50% result. You see that's a big group of cases which had good results, relatively good results. This is also an article recently from 2007 from Spain. There was patients with chronic pelvic pain not reacting on any treatment, and they also had a good result, but they made a little modification by placing the ground plate in the lower leg region. This is the slide. This is a slide of the poster presentation of the World Congress of Pain. So this is the same as I told you before. So what do we see with pulse radiofrequency? You see the stunning, an acute positive effect that may last 2 days, and the clinical improvement may set in within 2 to 3 weeks. So you have to warn the patient. If the pain comes back, wait a little bit, and you have a big chance that it will be better. The working mechanisms, neuromodulation, the doubts have arisen. We told already, the last speaker, when you told to have in the joint, the nerves are far away and still it has a good effect. Immune-inducing, several studies have been published about DRG applications in rats, and also PRF, low PRF fields have an effect on monocytes, and reduction of oxidative stress, and that's the explication probably of the stunning phenomenon. Then Taverner, in Australia, he wanted to prove that transcutaneous pulse ref didn't work. So he did this study, and the study was negative, which means that it worked. So this is the other publication for knee pain and for shoulder pain. What the mode of action must explain. So if we look at all the case reports and everything that has been published in the last 25 years, DRG, intradiscal, intrasacral, transcutaneous, intraarticular, systemic, trigger points, peripheral nerves, tendinitis, chronic pain models, and also injury sports, muscular tears, they heal much faster when you use radio frequency. And I use these generators. They also have the ability of RCT, of STP, What is the mode of action? The mode of action, various experimental neuropathic pain models in animals have shown that there's a pain relieving effect on mechanical hypersensitivity and thermal allodynia. It has been linked to the following events. Here you see the article of a rat model with a lump disc herniation model. They extract disc material and they put it into the epidural space around the nerves. What happens in a hernia? Then a group of rats were treated with pulsar DRG and the other group was sham. Here you see the experiment. The rat is being treated. So PRF elicited response at the dorsal horn from the glia, and the microglia and astrocytes, those are the immune cells of the neural system. And PulseRef reduces the microglial markers, OX42 and BDNF. These markers are signal molecules, and these drive not only pain processing and inflammation in the spinal cord, but also peripheral and central sensitization. So what you see then, after the animals were sacrificed, you saw that PulseRF had an anti-inflammatory effect. This is the sham group. Here you see the dorsal horn, and here you see the pulse radio frequency group, where you see that the inflammation is almost gone already. So the number of OX42 and microperk decreased after PulseRF. This is again the same as I told already from the publication. After this, Professor Aan, who did this publication, he was visiting me in September year, and he saw the results of sacral PulseRef, and he was positively influenced, and I asked him to do the animal model study in the sacral PulseRef, and he did that. And he published it, and you see the picture of it. And you saw that again, there was a good reaction on pulse radio frequency, and it was not only monosegmental, but it was also many multi-level segments in the spine. And then there's also a study being done in Korea on a very difficult to treat patient group, the chronic idiopathic axonal polyneuropathy. They didn't react on any treatment, 20 patients, and they were treated with sacral PulseRef, and 10 of 20 cases reacted well on this therapy. This is the PRF fields on on the monocytes. It expressed the TNF alpha, and also on the growth stimulation of plants. The other possible working mechanisms, it can stimulate calcium levels. It's promote calcium uptake in cultural cells, such as influences calcium-dependent processes such as synaptic communication, receptor activity, calcium-dependent signal pathway. And PRF has been shown to modulate the expression of calcium G-related peptides, which is a crucial player in the pain transduction pathway. And there are three other things. It suppresses pro-inflammatory excitatory amino acids. It triggers the endogenous opioid analgesia. And as I told you before, it has an effect on the inhibitive descending pathways. So there are many things happening with pulse radiofrequency, also centrally. So if you compare what is the difference between PRF and RF, thermal RF works on nociceptive pain and tests ablation. Okay, this ablation. So problems with the marker, sorry. Yeah. Now, thermal RF here works on nociceptive pain, mode of action ablation, targeted the efferent nerve, no effect on the target. Pulse frequency works on inflammation, oxidative stress. There's an anti-inflammatory effect by recombination of radical pairs, antagonizes cell stress, and has an improvement of the illness. And I tell you tomorrow in my lecture more about these mechanisms. But this is a poster presentation of the we treated 20 patients with fibromyalgia, and several patients had a good effect. So this is also a technique for fibromyalgia. And you can repeat the procedure if there are recidive. There are so far no complications. Only side effects, minor headache, and some local temporary pain on the os coccygeus. And I told you already 2 patients had a spinal tap because of the end of the dural sac. So our clinical observation is that sacral pulse application reduces severe neuropathic pain, refractory to conservative and interventional treatment, could diminish central sensitization. It should be further investigated. So I live in Amsterdam, and I see from my apartment this picture on the eye, where the cruises are reporting to other parts of the world. Thank you very much.
Thank you, Dr. Rohof, for especially the scientific explanation, the background of the treatment you invented. I know it's quite a lot of work to develop not only the clinical, let's say, results. If you see good results, then you don't know what's happening, and you explained it to us, and it's quite convincing, but maybe there is time for one question. Then we go on. We can always take questions at tea time.
Okay.
Then we go on with the next speaker.